I thank all the participants and everyone who works towards recruiting patients in our national frontline trials. I think all the hard work and dedication that goes into making these trials really the success that they are, and giving us all the information that comes through is really vital in how we continue to treat these patients in future. So thank you all. Today, we really have an opportunity to discuss treatment of our older AML patients with intensive and less intensive approaches in the context of our frontline trials, the AML 18 and the Victor trials. And I'm really delighted we have Professor Nigel Russell and Steve Napper, the chief investigators of AML 18, who are going to talk us through intensive treatment as well as the transplant experience in AML 18. And I'm also very grateful to Ian Thomas, partly for doing the whole organizing of this meeting. And he's also going to be talking to us about all the quality of life data that we are hoping to gather in AML 18 trial. And I think suffice to say that this kind of data is going to be quite vital, especially we're thinking about treating older patients with various different approaches in terms of intensity of treatment. So thank you, Ian. And last but not the least on the agenda this evening is Dr. Richard Dillon, who is the chief investigator of the Victor trial. I think many of you will be aware of the premise of the trial. It's very interesting in relation to comparing intensive versus less intensive approach for our NPM1 mutated older patients. So with this, I would like to really encourage all the participants, attendees to put their comments and questions in chat. I will try where we can to try and take some questions after every talk, but if not, we certainly want to address all of that in our Q&A session at the end. So please keep the comments and questions coming in the chat box. With this, I'd give the floor to Steve to start with intensive treatment in AML 18. Thanks, Steve.
Thank you, Priyanka. I'm just going to get my slides on the screen. Okay, hopefully you can all see my slides. So yes, thanks Priyanka, and thanks for joining us for this session this evening. AML 18, which is the national frontline study for newly diagnosed patients over the age of 60 who are considered fit for intensive chemotherapy, has been open for quite some time now. It first opened in late 2014, and although it's coming towards its end now, we really wanted to make sure people were fully enthused and updated on progress, because in the last stages now, we've got some important recruitment milestones to try to reach in the last few months that the study has got to run, to try to be able to best answer some of the questions we've set out to ask. So this first slide, I've tried my best to summarise where our current UK AML treatment algorithm lies. There've been quite a number of new drugs which have been NICE approved over the last 3 to 4 years. And I think we still break down into this traditional intensive versus non-intensive approach. So the left-hand side of this slide is really the summary of what we're doing with newly diagnosed patients who are considered fit for intensive chemotherapy now. There's been a fragmentation of the way we treat these patients because of the new new drug approvals over this time. When I used to use this slide to sort of present the treatment algorithm a few years ago, we just had DA, RSC, and whether or not we went to allogeneic stem cell transplant. But really, these NICE approvals of midostaurin, Mylotarg, and Vyxeos CPX351, they're all age agnostic and subcategorize different kinds of patients for different sorts of treatment. So what we do to a 60 to 75-year-old medically fit for intensive treatment patient really is predicated really on the genetics. And to draw your attention to these two studies which are still open for this age group of patients, namely AML 18 and Victor, which are the subject of this meeting. Of course, in recent months, just in the last couple of months, venetoclax has been approved in combination with azacitidine, but it is very much based on approval for the less fit patient either over the age of 65 or over the age of 60 with significant comorbidity. So it really shouldn't theoretically impinge too much on those patients who are considered fit for intensive chemotherapy. So it's traditional to look at recruitment over time, but this recruitment timeline really gives a sort of idea of various different world events that have happened over the period that AML 18 has been recruiting. So as I say, we opened for the first time in November 2014. There was the expected gradual increase in recruitment as sites came online, but when we were sort of hitting our peak, we were getting upwards of 30 to 40 patients per month at steady state going into the study. This then fell off quite considerably at the beginning of 2019 when we shut the adverse risk arm of the study, and then it obviously fell off a cliff in the early part of 2020 at peak COVID. And since sites have sort of got going with their intensive chemotherapy schedules and trial recruitment during the COVID pandemic, we're tending to hit about 10 patients randomized per month, and it's really important we keep that going, at least that going, and potentially a little bit more over what the time we have remaining of recruitment in 2022 to hit some of the targets we want to hit. Again, traditional to show recruitment by centre, and it's the kind of usual suspect centres who are at the top of the recruitment league table. But the column on the right shows how recruitment has varied with the current design of the study, with the CPX versus DA randomization, and some of the usual suspects have possibly not done quite so well in this new randomization, and other sites have done particularly well. And it's just to emphasize how much we've depended on collaboration with our Danish sites as well to boost these recruitment figures. So going back historically, this is what AML 18 looked like when it originally opened. We had a randomization between 2 doses of Mylotarg with intensive chemotherapy for patients not known to have adverse risk cytogenetics. We had a treatment intensification randomization for patients with residual disease detectable by immunophenotyping after cycle 1, and then we had some further randomizations with small molecules, particularly quizartinib or AC220, further down the line. It's important we emphasize some of the important outputs that have already been presented from AML 18, and Nigel very kindly agreed to let me present the highlights of his EHA 2021 presentation, which was the outcome of this initial randomization of patients between 1 and 2 doses of gemtuzumab Mylotarg at the point they were recruited to the study. And I'll whiz through this pretty quickly in the interest of time. The reason we were asking this question was because we'd always used a single dose Mylotarg regimen, and the study that preceded AML 18 for the over 60s, AML 16, clearly demonstrated benefit for Mylotarg versus no Mylotarg in that age group. At the same time, the Alpha study based in France used a fractionated Mylotarg regimen where patients actually got 3 doses of Mylotarg with cycle 1 of treatment. And this was the dosing schedule that formed the basis of the NICE approval of gemtuzumab, although it was based on much fewer patients than we'd actually treated in the AML 16 study. So AML 18 on opening asked this question: does a fractionated schedule of Mylotarg have any impact on the relapse risk and overall survival compared to the single dose that we've been using before in this over 60s age group? So these are the patients that were recruited in this first part of AML 18. A total of 847 patients were randomized between 1 and 2 doses of Mylotarg. And looking at the demographics of those patients, as you would expect, the median age was about 68, and as you would expect, the vast majority of those patients had intermediate risk cytogenetics. The 14% with adverse risk were patients who were not known to have adverse risk at the point of entering the study, but their cytogenetic results later came through and showed them to have adverse risk disease. Generally, the fractionated schedule with 2 doses was pretty well tolerated. It didn't really have any impact on 30-day mortality or the relative reports of adverse events. There was possibly some slight delay, a trend only, in platelet recovery, and there was a statistically significant slight excess of number of units of platelets that patients needed when they were having 2 doses of Mylotarg. Overall, we didn't see much difference in response rates, so complete remission rates after 1 cycle of chemotherapy were exactly the same. There was possibly a slight higher number of patients with complete responses with an incomplete count recovery in the fractionated Mylotarg dosing group, but when we looked at patient response rates after the end of cycle 2 of chemotherapy, that all evened out, so we weren't really seeing any evidence to support better overall response with the fractionated dosing. Overall survival curves completely overlapped. We didn't see any improvement in overall survival with the fractionated dosing. Likewise, we didn't see any improvement in terms of cumulative incidence of relapse. So this was essentially a negative study. Interestingly, the premise from AML 17 on which we based the need for intensification randomizations after first cycle of chemotherapy was Sylvie Freeman's data showing significantly worse overall survival in patients in that study that were flow MRD positive on recovery from their first cycle of chemotherapy. Interestingly, we haven't seen this to be the case at all in the AML 18 study, where 3-year overall survival between MRD positive and negative patients has been the same, and there have been various theories for that. Perhaps the one with greatest credence is that a much larger proportion of patients have had transplants in first complete remission in the AML 18 study. Possibly some of those patients would have had intensification of treatment following cycle 1 as well, but it's an interesting difference between the 2 studies. So to summarise what Nigel presented at EHA, there was no survival benefit with the fractionated GO schedule, although there was a trend for higher CR/CRI rate after 1 course of induction. This seemed to even out after 2 cycles. There was not really much difference in toxicity, although there was a little bit more platelet support required with the fractionated schedule. So that brings us on to just a revision of where we are with the current trial design and some reminders, hopefully, to enthuse you with what you're doing over the next few months that the study has to run. So the current trial design is looking at a randomization of patients not known to have adverse risk cytogenetics between our standard of care DA with 2 doses of Mylotarg schedule and CPX 351, and it's a 2-to-1 randomization in favor of CPX. We still have the dose intensification randomization for patients who are MRD positive after cycle 1, whether that's an increased dose of CPX for cycle 2 or a switch to FLAG-IDA for cycle 2 if you're in the control arm. And we still have randomizations open where patients in the DA arm who have a FLT3 mutation can be randomized to the addition of the FLT3 inhibitor quizartinib, AC220, if they're FLT3 positive, and also patients can be randomized for their 3rd dose of chemotherapy between DA2 plus 5 and intermediate dose cytarabine. So we'd very much encourage you to remember those later randomizations. This slide just summarizes what I've said, and I'm going to move through that in the interest of time. And this slide, this is more, you can refer to this when you access the slides after the presentation this evening. This just points you to which patient information sheets and randomization forms you should be using at these different points when patients are having these different randomizations. CPX DA, the intensification randomizations with CPX or with standard chemotherapy, and the randomizations to AC220 or not, and to DA versus intermediate dose cytarabine. Just a word or two about the rationale for why we're doing this randomization with CPX 351, sorry. Most of the data in support of CPX 351 and the data on which it was approved for patients with therapy-related and post-MDS AML were based on this company study, which was the JAZ 301 study. This was, again, patients aged 60 to 75, but it was restricted to very specific groups of patients. Those with therapy-related AML, those with a history of prior MDS or CMML, and they either needed that prior history or they needed confirmation of an MDS karyotype. These were the headline results of that study. So there were significantly better response rates with CPX 351 and the study met its primary endpoint, which was improving overall survival in that group of patients. It should be emphasised that the control arm in that study was only 7+3. It didn't involve Mylotarg, and it involved a lower dose of chemotherapy than we're used to giving in the UK in our 3+10 schedule. But this was the basis on which liposomal cytarabine daunorubicin, otherwise known as Vyxeos, was recommended for this specific group of patients with previously untreated therapy-related AML or that following a myelodysplastic syndrome. The reason we are asking the question we are in AML 18 is that the company prior to their 301 study did a wider ranging phase 2b study where they also looked at some patients that had de novo AML, and they found quite encouraging rates of response and tolerability of treatment in that group. And that was really why we wanted to ask the question of whether CPX-351 also potentially benefits patients with non-adverse risk disease. So the aim of the study is not to repeat the 301 study, it's to ask the question in the de novo AML population with non-adverse risk disease. And the way we thought to answer that question quickest was to use a 2-to-1 randomization design. So we're excluding patients with known adverse risk cytogenetics, either the Grim-Wade karyotype or those with the MDS-related karyotype. And we're excluding patients with therapy-related AML. The other thing that's kind of changed with AML 18 in the last few months, and the other thing to sort of update you on in this meeting, is we've changed our primary endpoints. Though when the study opened, the primary endpoint of the study was all based around overall survival. We've now had MHRA and ethical approval to change to a co-primary endpoint, where we're also looking at event-free survival, where an event is defined as either death, resistance to the first course of treatment, or disease relapse. And I'll illustrate why we've done that based on this recruitment curve. So this shows again from this is from the study opening to now, and the dotted lines are the actual numbers of patients that have been recruited to the study. This was the red dotted line was the initial intended recruitment, and the blue dotted line was what's happened with COVID and various issues that have happened over the last 2 to 3 years, which have clearly significantly delayed our study recruitment. Now, we'd initially targeted 600 patients going into this part of the study from 2019 up to the end of the study. And that would clearly be an unfeasible target given the way that things have slowed down in recent times. To get to the overall survival-based target of 441 events, we would have had to go well beyond what we're funded to do. And using an event-free survival target instead, we're getting to a 376 events, which is necessarily for statistical significance by the second quarter of 2025. And that's predicated on continuing to recruit patients at the current rate or slightly better until the end of 2022. So we really need your cooperation as enthusiastic recruiting sites to be able to do that. We're still interested in the MRD driven questions, and Sylvie continues to run this through the lab in Birmingham, and we continue to offer these dose intensification questions after the first course of treatment and the availability of the MRD result following the first course of treatment. We're still looking at MRD based questions in both the standard arm and the CPX arm of the study. These were the numbers of patients we recruited during the first part of AML 18, so more than 500 patients were recruited to this treatment intensification question. Since we switched to CPX Diego, we've continued to recruit pretty well. We've recruited another 120 patients into the amended design. There are twice as many going in the CPX arm as the DA arm, because it's a 2-to-1 randomization, and twice as many patients are going into the CPX part of the study. So we very much encourage you to continue offering that to patients for what we remain of the study, and that's going to generate some potentially quite powerful outputs from the study relatively soon. So just to go back to the trial design, I'm not sure I have very much new to say about this slide now. Just to say, remember quizartinib, AC220. So if your patient is in the standard risk arm of the study and gets and continues down that arm of the study, whether they're getting FLAG-IDA or DA with their second cycle of treatment, they can, and they found to have a FLT3 mutation, they can be allocated either AC220 or not. So we've treated about 200 patients with AC220 in the AML18 study so far. So it's important to carry on adding to that number if we can. And then finally, to emphasize that we are still recruiting to the consolidation randomization, and this is for patients in the DA arm of the study that remain on the DA arm of the study. So it's a small proportion of a small proportion, but we'd like to carry on offering it if possible, that patients going into cycle 3 of treatment can be allocated either DA or intermediate dose cytarabine as that third course of treatment. So final reminder, inclusion criteria and how it impacts your patients at the moment. So essentially, we're interested in patients who have de novo AML, who are over 60, are suitable for intensive chemotherapy, and that does include patients who have dysplastic morphology but don't qualify as AML with myelodysplastic related changes based on preceding therapy or preceding history of MDS or cytogenetics. So those that just have AML MRC based on morphology alone are still suitable for the AML18 study. Indeed, patients with myeloproliferative neoplasms that transform to AML are also potentially eligible for AML18 if they don't have adverse risk cytogenetics. So continue to bear those patients in mind. Exclusions, as we've said, are patients with therapy-related AML, patients with known adverse risk cytogenetics, and patients with a prior history of MDS. But if you're unsure about where your patients fall on either side of this cutoff, we're always very happy to discuss eligibility of an individual patient before we confirm whether they're eligible or not. So please do let us know. So final slide. AML18 has never officially closed throughout the pandemic, although it dropped to a very low level in the early stages. We've been able to sustain recruitment, and we thank all collaborating sites for their efforts in being able to do that, and obviously patients who have agreed to go into the study. We've managed to get 380 patients into the CPX DA Go randomization despite everything over the last few years. So we'd really like just to go that extra mile to generate those numbers that are crucially going to be required to answer the question in a timely fashion. Recruitment's going to continue up to December of this year, and don't forget these other easily forgotten randomizations with AC220 and the consolidation randomization. So I'm going to stop there, and I'm going to stop my sharing. How do I do that?
Thank you very much, Steve. That was a fantastic overview of what we know so far from AML18 and where we are headed. You have finished a little ahead of time, so I'm going to invite questions. There's one in the chat just now. Let me ask a quick question myself, Steve. You mentioned the 30-day mortality. These are older patients over 60 getting intensive treatment, and I think 7.3%. How do you view that? Are you fairly reassured with that mortality figure? Does it surprise you at all?
I think that is about what I would expect, actually. I mean, it's slightly higher than we would see in the under 60s population traditionally, but I think it's probably typical of what we've seen across the older intensive chemotherapy studies.
Do we have an idea about what proportion of that might be due to just refractory disease, or do we assume a lot of that is treatment-related mortality?
I mean, it's within the 30 days. I would say that the majority of that would be treatment-related. I don't have in front of me. Nigel may know this, the 60-day figures, and they would obviously start to be impacted a little bit more by refractory disease, but no, I'm not absolutely sure about that.
I could mention, if people can hear me, I think it was about 10% 60-day mortality, no difference between the arms, and that would include refractory disease.
Thanks, Nigel. That's really helpful. I'm looking at the chat box, and there aren't any other questions there. Just Steve, just another question about the MRD positive and the MRD negative, because that's real change from what we saw in AML-16, as you showed Sylvie's data. And, as you mentioned quite rightly, it might have been due to the fact that more patients were transplanted. But do you think the role of intensifying when someone's MRD positive has also worked?
I don't know. I mean, I guess we're gonna have a go at seeing that answer when we close the randomization and start looking at that. I mean, it's obviously they're very interesting data, and I guess the fact that the MRD negative, not all of those MRD negative patients will have, not all of those MRD positive patients will have necessarily had intensified treatment second course, because some of them will have been in the control arm, of course, and had standard of care treatment. So it can't just be that, but it is. I mean, it is encouraging. I mean, I guess the bottom line is it's great to see that these patients are doing better in the AML-18, and whether that's due to intensification or transplant, but it's going to be interesting.
Priyanka, can I just make a couple of comments about that?
Yes, of course.
We're asking the data monitoring committee whether we can analyze that randomization and present that close the randomization, and because it's recruiting quite slowly, and we think we're certainly in the DA arm, in the standard, not the DA go arm, not in the CPX arm. So that's one question. The other thing is the quizartinib randomization. It's really there's a lot of patients in there. There's over 350 patients randomized to quizartinib or not. So this is going to contribute significantly to our knowledge of upfront use of quizartinib. The Quantum First study has closed and has been reported to be positive in terms of survival. But I don't know that anybody's seen the data. But we've got a lot of patients in AML-18, older patients, that will contribute to our knowledge of the upfront use of quizartinib, for example, compared to midostaurin or other FLT3 inhibitors. So again, we're hoping to close that randomization, because really it's only being recruited in our New Zealand sites at the moment, because obviously for patients in the UK, there's alternative approaches available with midostaurin. So just a couple of quick comments.
Thanks, Nigel. That was very, very useful. Whilst we're on the subject of induction, the GO1 versus GO2 doses, do we think this is going to be a practice-changing finding for us in the UK?
Well, just a comment on the Go1 versus Go2. I saw we've got another year's follow-up on that now, and I saw the results earlier today. And although there is no significant the difference is not significant, the benefits is in favour of Go2, which is why we chose Go2 to take forward to the CPX randomization, and why it's been taken also forward in the Victor randomization as well. So we do think there is a benefit from Go2 compared to Go1, although and we will meta-analyze.
Nigel, we've lost you. We can't hear you very well just now.
With 2019 and AML-18 together, the meta
You just broke up a bit at the end, Nigel, about when you were talking about the meta-analysis. So just to say, I mean, I think that Nigel was saying that because Go1, Go2 was also has...
in that meta, Go2 with AML.
There's a meta-analysis that's going to happen between AML-18 and AML-19 Go1 versus Go2 data, and that should generate some quite powerful findings as well.
Excellent. Thank you, Paul. I can see you've raised your hand. It's time for us to move to Nigel's chat. Paul, any chance you can put your question in the chat and we'll try and come back to it? Thanks. So over to you, Nigel. Nigel, I'm just thinking if your internet is not quite strong enough, you might want to turn the video off, because that might just make your audio a bit more clear and continuous.
Okay, that sounds very sensible. Right. I hope you can hear me now. I'm going to share my screen. Now, can people see that?
Not yet, Nigel. We can hear you all right, but we are not seeing your slides yet.
That's great. It worked before when we were in practice.
Yes.
Hello?
Yeah, hi, Nigel. We're waiting. Do you want Ian to flash your slides and you can just ask him to move those forwards?
Yeah. Ian, do you want to put those slides up?
Yeah.
Can you see that, Nigel?
Okay. Thank you. Transplant in older patients, and this is an abstract that was presented at EHA end of last year, and I'm going to add to that. And the title was that sequential NCR-AML trials show consistent benefit for transplant in CR1 that was independent of MRD status after first induction. So next slide, Ian. Can you move on? Okay. So if you look at the post-remission therapy options in older patients with AML, although as we've seen, about over 75% of patients over the age of 60 can go into remission, only about less than 20% will survive at 5 years. Thus, interventions aimed at preventing relapse are top priority. So the options are consolidation, maintenance therapy has emerged as an option, and reduced intensity conditioned transplant, which is made available allotransplant to older patients. And finally, and also the patients who achieve a CR but are MRD positive are known to have an adverse prognosis and to be at higher risk of relapse following a RIC transplant. Next slide. A bit of a delay on this. Can you show the next slide, Ian? Okay, so we've undertaken 2 consecutive trials for patients over the age of 16, and some will remember AML 16 ran for 2006-2012. AML 18, as you know, has been running for the last, well, we're looking at the DA-GO data, so it'll be the early part of AML 18, which ran from 2015-2019. Both trials employed double induction, as you know, and clofarabine in the AML 16, Ara-C and GO in AML 18, and followed by consolidation. Then there's, as you know, there's a treatment intensification option in AML 18, which Steve has gone through. And patients in remission, CRR or CRI, who did not have favorable risk cytogenetics, so we didn't recommend allotransplant for favorable risk cytogenetics, in other words, the core binding factor leukemias, these patients could undergo a RIC transplant or suitably matched unrelated. Next slide. So in AML 16, there were 932 patients who aged 60 to 70, median age 65, who underwent a RIC transplant, who were studied with RIC transplant given to 144, so just 15%, 144 out of 932. In AML 18, we looked at 648 patients in CR1 in the DA-GO1 versus DA-GO2 randomization. And RIC transplant numbers increased dramatically up to 31%, so 201 patients. And the median follow-up from CR was 45 months. So as you know, MRD was measured centrally, and comparisons of RIC transplant in first remission or not were carried out with the classic MRC Amantle bioanalysis. Next slide. The demographics of 16, who had a RIC transplant with those who didn't, RIC versus no RIC. It was slightly younger, 64 versus 66, perhaps not surprisingly. Slightly better performance status. This was significantly different. More patients with a a performance status of 0. And in terms of the weekly risk group, which is a analysis based upon cytogenetics, age, performance status, and a number of other factors, there was a selection, more patients in the RIC transplant arm had a good weekly risk group, and fewer patients had poor weekly risk group. So there were differences in selection between the RIC transplant and the non-RIC transplant patients. Next slide. The advantage of the delay in the slides is you've got more time to study them. Next slide. Oh, wait a minute. Okay, so we have got the next slide. This is the headline results with the AML 16. Remember, this is a trial from several years ago now. This is 5 years headline results. Overall survival was significantly improved by RIC transplant, 37% versus 20%. This is due to a significant reduction in the risk of relapse from 83% to 43%. And the non-relapse mortality was 39% in the RIC arm, so quite significant. But if you remember, it was 11% in the chemotherapy only arm. So the difference was about the excess mortality was 28% in the RIC arm, which was obviously significantly different. So significantly increased risk of treatment-related mortality, which is not surprising. Next slide. This is a survival curve, the mantle bioanalysis in favor of RIC transplant at 5 years, as I pointed out. So survival of about 37% compared to just over 20% in the no transplant arm. So 15% of patients had transplant in AML 16. Next slide. This is the reduction in relapse, which is significant in favor of RIC transplant, so halving of the risk of relapse. Next slide. This is the look at the analysis of the weekly risk group, and on the left-hand panel is the 3 different risk groups in terms of survival in a population of older patients with AML: good risk, intermediate risk, and poor risk patients. And you can see here that the weekly risk group neatly segregates these patients into 3 groups. If we looked at the impact of transplant on these various groups, we found that there was no heterogeneity, that all groups benefited. The good risk, the standard risk, and the poor risk group of patients all benefited, and it appeared to be equal benefit in terms of the benefit of RIC transplant. So it wasn't just the good risk patients that were benefiting, it was all risk group of all 3 risk groups. Next slide. And this is the actual survival plots. Left-hand panel, good risk patients. The middle panel is the intermediate risk, and even the adverse risk patients showed benefit. Next slide. Now, this is the MRD analysis, and you've seen this panel, this left-hand panel before, because Steve showed it in his talk. This is the AML 16, the outcome for those who are MRD negative versus for those MRD positive. This is globally. This is whether that had nothing to do with transplant, or this is survival based on post-course 1 MRD. It was doubled in the MRD negative. So we asked the question, where was the benefit for transplant? And really, we couldn't see what we found was that all groups benefited, whether MRD negative, MRD unknown, MRD positive, and even those patients who didn't achieve a complete remission post-course 1, there was benefit for allotransplant. So all 3 groups of patients, well, 2 groups of patients, MRD positive and MRD negative, but these other groups also benefited. So we couldn't find a subgroup that didn't seem to benefit from allotransplant. Next slide. We looked at molecular data. This is just looking at the patients by FLT3 status. Again, shifted to the left, benefit for transplant was clearly seen whether you were FLT3 wild type or FLT3 mutant. And in this study, there was also equal benefit for patients who were FLT3 NPM wild type or NPM mutant, as you can see here. So again, we couldn't find a group of patients that didn't appear to benefit from allotransplant from CR1. Remember, we excluded core binding factor leukemias from this analysis. Next slide. So basically, the conclusion from that part of the study, and this was published, I think, last year in British Journal of Haematology, or was it Haematologica? I think it was Haematologica. So when we adjusted for the clinical features of the disease, RIC transplant in CR1 significantly improved survival in older AML patients, but was only performed in a minority of patients, just 15%. Sibling allografts did tend to perform better than mud transplants, although the difference didn't reach statistical significance. And analysis by the Wheatley risk group and by molecular status or by MRD post-course 1 showed no evidence of a differential effect, and we couldn't identify a group that did not benefit. So moving on to the next slide. So in AML 18, when we devised AML 18, as AML 16 had found no group that did not benefit from transplant, the decision for transplant in the ensuing AML 18 trial was based on health status and donor availability. So in the analysis I'm going to show you from AML 18, 648 out of 847, so 76% of patients achieved CR. And unlike AML 16, the outcome for post-course MRD patients, as Steve has shown you, the outcome for patients who are CR MRD positive was not different to those who were CR MRD negative. So the left-hand panel is what you've seen before. AML 16, the big difference in outcome. In AML 18, to our surprise, and I still find this surprising, the benefit for MRD positive, the lack of the disbenefit for MRD positive is not apparent. So the question is, what is the reason for that? And this, we've alluded to this already. We know that there's a treatment intensification question for patients on AML 18, and that could be one reason, or it could be a role of transplant. So let's, the next slide, please, Ian. So when we looked at, we've done a mantle bioanalysis for RIC transplant versus chemotherapy. So this is from last year. So as I pointed out already, the transplant numbers in AML 18 has more than doubled, 15% in AML 16, 31% in AML 18. And this interim analysis confirms the AML 16 result of a benefit for transplant with a 3-year survival from remission of 48% versus 37%. And an update on this I've just seen earlier today confirms this benefit. So we're seeing a consistent benefit across the two trials, AML 16 and AML 18 for RIC transplant. Next slide. So the question is, we're interested in the interaction between transplantation and MRD and AML 18. But what we found was that the observed benefit of transplant was independent of post-course 1 MRD status, and this was consistent with the AML 16 result. In other words, both those patients who are MRD negative and patients who are MRD positive benefited to a comparable extent. But what we found was that the transplant rate was higher in patients who are MRD positive compared to those who are MRD negative. The transplant rate in MRD positive patients was 36% versus just under 25% if they're MRD negative. So you out there in your trusts and your hospitals had been choosing to transplant MRD positive patients based upon, I think, the poor results that these patients achieved in AML 16. So this selection was not surprising. So as the majority of transplants, 80% of transplants took place after courses 2 or 3, we examined the impact of the second induction on MRD status and transplant outcome, in those who were not initially achieving an MRD negative CR. So overall, 59% of patients who are MRD positive post-course 1 became MRD negative post-course 2, and we found that the benefit of transplanting was greatest in these patients compared to those who remained MRD positive. So the hazard ratio benefit for transplant was 0.32 in favour of transplant for those who, as it were, converted from MRD positivity to MRD negativity, whereas the benefit was less certain, less clear for those who remained MRD positive post-course 2. The next slide, I think, may show this in perhaps better detail. So this is a slide that Sylvie Freeman gave to me, actually. So if patients not MRD negative after course 1, 63% converted to MRD negative post course 2. Whether that's a result of the treatment intensification remains an open question. And the benefit of was great. And this is a nice forest plot which shows the benefit for the MRD negative patient. Hazard ratio 0.32, confidence intervals 0.11 to 0.92, compared to those who remained MRD positive. So I think, although not conclusive evidence, it does suggest that, that achieving MRD negativity prior to allotransplant is a positive thing. Next slide. Particularly those who remained resistant first time round with first induction. So just to summarize, 2 consecutive trials in over 1,500 older AML patients demonstrated a consistent benefit for RIC transplant in CR1. This benefit was independent of their post-course 1 MRD status, so both groups benefited. For both post-course 1 MRD positive patients, the benefit of transplant appeared greatest in patients who convert to MRD negative remission post-course 2, although benefit for those remaining MRD positive cannot be excluded. So I wouldn't exclude patients on that basis. And the overall improvement in outcome in MRD positive seen in AML 18 compared to 16 may reflect the increased uptake of RIC transplant and the use of post-remission treatment intensification. So what I now want to dwell on for a few minutes, if I'm allowed, is to ask the question, can we improve on our ability to identify who benefits of transplant? I think it's an important question. Next slide. So this is interesting data just published a year or so ago in Blood Advances from the French Alpha Group 1200 study, which shows that patients with a secondary AML-like gene mutations in ELA and intermediate risk older patients. So this is patients over the age of 60, looking at the benefit of transplant or not in those patients who have secondary AML gene mutations. On the right hand, these slides aren't particularly good, don't project particularly well, but the right hand panel shows a clear benefit for transplant in those patients who with secondary AML mutations, and those who had ELN adverse karyotype and ELN intermediate with their secondary AML mutations. I hope I've explained that clearly. So patients who with ELN intermediate classification without secondary AML mutations, the left-hand panel didn't appear to benefit. So this is interesting analysis, and it may help pinpoint those patients who should be taken forward to transplant in CR1. Next slide. So what relevance does this have? So we know that that is work from Paresh Vyas's lab on AML 18 patients. We know that a lot of patients who entered AML 18 have what we call cryptic secondary AML. So there's a lot of evidence in this from a variety of analyses, the Oxford analysis with Paresh, but also the Sanger MSKCC NCRI collaboration with Eli Papamanuel and Brian Huntley. And they identified this is Sanger sequencing on over 2,000 patients from AML 16 and 17. They found 2 classes of secondary AML-like disease, and this paper is just published online. Those with one single secondary AML mutation, they're called SAML1, and those with more than one mutation, so SAML2. And this comprised these over 31% of patients. But only less than a third of these patients with secondary AML-like gene mutations actually had a history of antecedent hematologic disorder. These patients tended to be older, they had a lower blast cell count, and particularly poor outcome, particularly if they had a history of AHD, but most of them didn't. 2/3 didn't have a history. And the collaboration with Paresh on AML 18 sample was over 1,000 patients, median age 67, and identified secondary AML-like mutations in just under half the patients, and only 20% actually had a history reported of antecedent hematologic disorder or had high-grade MDS. So again, a significant proportion of patients, of older patients, had these cryptic secondary AML genomic signature, not present, that was not as it were detected based on their history. Next slide. So what relevance has this got? This is, can we move, I think this is 2 slides. That's it, great. So this is just to say that looking at the bottom, the left-hand panel, this is data from Ellie Papamanuel's publication and Brian Huntley's talk at the AML Academy from last year, looking at the benefit of transplant in patients with secondary AML. And you can see here that on the bottom left-hand panel, sorry, this is to show you the difference in survival between patients with SAML1 and SAML2. SAML1 in the green curve, SAML2 in the blue curve. Patients with more than one mutation have a particularly poor survival. The next slide, I think, shows the benefit of transplant. I think this may be another slide you can press on, Ian. And this shows the benefit of transplant is particularly seen in these SAML patients. And this is a slightly unusual analysis. It's looking at the top, if you look at the top 3 curves here, this is looking at the benefit of transplant. So where they're looking at deaths per person per year, and the patients who are transplanted are in the gold color, and the non-transplanted are in the blue, are in the gray color. And you can see here there's a lower death rate occurring in patients with secondary AML, SAML2. SAML1 is less clear, but SAML2 certainly is benefiting. And also those patients with TP53 mutations benefiting from transplant in first remission, which is often an asked question. So SAML2 benefit from transplant, but no effective timing, whether it was CR1 or CR2. SAML1, CR1 transplant appeared to benefit, and TP53 mutation patients also benefited. Next slide. So this is, and that's just to flag that up. If you want to see that data, there's a Twitter feed from Ellie Papamanuel's lab, which is worth reading. It's a very nice run through of her risk classification. And there's the online publication as well. So that will be on the slides that you can access. And the next slide. Just to say that when Paresh looked at those over 1,000 AML18 samples, we could break survival down into these 3 groups. The patients with a de novo AML gene signature, the top curve, patients with secondary AML gene signature as an intermediate curve, and the patients at the bottom were about the 10% of patients that had TP53 mutations. So the secondary AML patients are clearly doing worse in AML18 than patients with de novo AML. So one of the questions we need to ask is where can we see the benefit for transplant in these different groups? Will we see a benefit for transplant in those patients with de novo AML, or will it be confined to those patients with secondary AML, as suggested by the Alpha study? Next slide. We haven't done that analysis yet, it's ongoing. So summary, some people say that all older AML patients should have a RIT transplant. What is my view? So I would say no, I don't think that's true. Clearly you should exclude patients with favorable cytogenetics, those patients with core binding factor leukemias. I think with older patients with NPM1 mutated AML, although the AML16 results showed a clear benefit, that was without the presence of GA-GO, and gemtuzumab. There's good evidence that, or we've got good evidence that gemtuzumab, it does benefit NPM1 mutated AML, so I wouldn't necessarily take all NPM1 mutated patients to transplant in CR1, but I would monitor MRD and follow the Adam Ivy, David Grimwade pathway in terms of that decision-making process. What about those patients with de novo AML gene signature without adverse cytogenetics? And I think that's a question that we need to try and address in our AML18 cohort, and that's ongoing. So who should have transplants? Clearly, those patients with adverse cytogenetics, although the benefit is least there. Those patients with secondary AML or secondary AML-like mutations. And there's a question whether that should be SAML1 or just SAML2 only, and that's something, again, we'll be addressing in AML 18, and those patients with TP53 mutations. So I'd like to finish there, Priyanka. Thank you very much.
Thank you very much, Nigel. That was a fantastic tour de force on transplants for all the patients. Sorry, I'm getting feedback. I'd like to invite people to put questions in the chat. And I'm sure there'll be lots of questions regarding transplant in older patients, Nigel. But if that's okay, we'll ask Ian to do his talk. And there'll possibly be some time at the end of that for us to take a few more questions then.
Fair enough.
Thanks, Priyanka. Hopefully I'm coming through loud and clear. Can you see that?
Yes, thanks, Ian.
Excellent. Right. So this will be quite a whistle-stop tour of the title here, Quality of Life Reports in AML Trials. So I'm just going to go briefly through what we already do, which the participating centre teams will be quite familiar with, what the current status of our data is, what we've done with previous sets of quality of life data, which you may or may not be aware of, and then what we want to do next. So what we collect at the moment on a patient-reported basis are 3 questionnaires bundled into one, so that this will all look like one questionnaire to a patient. The EORTC QLQ C30 questionnaire was developed in the mid-90s and was actually developed to be used in solid tumour cancer trials. So there is some debate about whether it's the best tool for us to use, but it's the validated tool of choice. EQ5D is particularly important when drug data is taken to licensing agencies. Quali measurements are based on EQ5D data, so it's important that we try and maximise the impact of our trial data by including that. And then there's an additional short questionnaire about anxiety and depression, which we're looking to agglomerate with similar data from other blood cancers and possibly a broader cancer data set to look into anxiety and depression on a patient-reported basis across cancer trials. The timelines that you'll be aware of, you will at participating centres, you'll probably receive an email as soon as you put a patient into any of our trials, encouraging you to get the patient to do a pre-treatment baseline quality of life questionnaire. The other time points, 3, 6, and 12 months, are aligned with post-induction, post-consolidation, and an annual follow-up, if you will. From July 2019 of the AML 18 trial, when the CPX randomisation was opened, we added a 1-month post-course 1 questionnaire. The company Jazz were particularly interested in patient-reported data after 1 course, and they still feel that this is going to be important data for them. Okay. So in summary about the data that we've received back from centres, I mean, the numbers are pretty staggering about the number of patient questionnaires that we've received back, and the percentage of expected questionnaires. Obviously, it will tail off as patients either progress or move away from their treating centre, which makes operationally it a bit more difficult for centres to provide the data to us. But obviously these applause signals are a great thanks to all the participating centres who've helped us gather in all this data. That from the point of view of data analysis and quality of life data, it's not a yes/no set of data, so you need a lot less patients to get some meaningful results out of patient-reported data. So these are very big and very meaningful data sets for us. So what have we done with data like this previously? Well, in the elderly but frail population, Megan Otis and her colleagues in Seattle took some of our AML18 and LI1 data and compared it to some US data to try and use patient-reported elements within a predictive model. So what she was trying to predict in her group was the predictive power of different clinical and demographic elements and also patient-reported elements at baseline, and how those data helped predict 28-day mortality. So just to give you some background to these numbers, a 0.5 predictive score would effectively be the toss of a coin, no predictive value. So as you can imagine, gender wouldn't necessarily be a very strong predictor of early mortality in this group of patients. Of the clinical and demographic data, white blood cell count at entry was most meaningful. But when you look at the patient-reported data from this QLQ-C30 questionnaire, you can see that a number of the functions within, a number of the scales within the questionnaire were more predictively powerful than any of the clinical and demographic data. So this is a modelling exercise in that all these elements were put together within one predictive model, but these functioning scales, physical and role functioning, are very similar in that it measures a patient's activity. Fatigue and appetite loss won't be particularly surprising to most of you who treat these patients, that is predictably powerful of not positive response. In the younger patient population who received intensive treatment, these are APL patients. Alan Burnett analysed and published some data back in 2015 when comparing ATRA with idarubicin against ATRA and arsenic trioxide. Obviously, this is in the younger patient population. And all the different functioning scales within the EORTC quality of life questionnaire were compared between the two arms, and you can see that there's pretty strong evidence that the patient-reported element of this comparison favoured ATRA and arsenic trioxide. This data, even though it was the primary endpoint, it wasn't statistically significant enough for this data to be used as the primary source of licensing. However, this patient-reported element was important in arsenic trioxide obtaining the license in that group of patients. So it is important to licensors, to funders, and obviously it's important to patient groups that we use the data that we collect. You would have seen the flow chart for the trial already. These numbers here are randomizations going into AC220 long and AC220 short on both arms of both sides of this comparative arm. Both Nigel and Steve have already mentioned the importance of the AC220 randomization, and Nigel mentioned the quantum first data which is emerging. We will be looking to analyse the AC220 arm later this year, and this quality of life element will be an important part of this analysis. So with this number of patients, I think Steve mentioned earlier, over 200 patients have been randomised to receive AC220. Obviously, there's a comparative group who would have received either DA or FLAG IDA only. This is the timelines that I mentioned earlier. Baseline is obviously pre-induction, so if we're going to compare the AC220 experience, we would start at post-induction, which effectively becomes baseline for this group of patients. And the experience at 6 and what would then be 9 months through AC220 treatment will be important, given that the long AC220 patients will still be on treatment at this point. The short would still be on treatment post-consolidation, but the DA FLAG IDA patients would have had a completely different treatment experience. What we're looking to do beyond the AC220 randomisation on a more landscape basis, Blood Cancer UK have provided funding for us to look at quality of life and outcome in patients specifically with 20 to 30% blasts. We're going to start looking at fatigue in particular in that MDS type population, and looking at whether predictive power and the comparison between intensive and non-intensive patients throws up any meaningful data. Patient representatives are quite an important part of that funding application and that analytical group. What we don't do at the moment is go beyond that 1 year or 12-month time point. So there is a worldwide dearth of patient-reported data beyond 1 year in the elderly AML patients. There's plenty of data emerging in the US from the younger patient populations in regard to survivorship and what might be termed living with a history of cancer. This might involve return to normal social activities, ability to work, etc. So even though that might be slightly less relevant in this elderly population, the retirement age actually means that there is a requirement possibly to measure the ability to return to work even in a patient who's going into a trial at 60. Some of our group have already started some focus questions and analyses about different treatment agnostic elements of the patient population themselves. So whether there's any differences in quality of life and the trajectory of quality of life through treatment in regard to ethnicity, gender, different age groups, potentially under 70s versus over 70s. And also Robert Hills has analysed and published data before about the impact of being in remission on patient quality of life versus not. Steve mentioned earlier Sylvie Freeman's MRD data, and that could be part of the same type of analysis. This set of talks today is focused on the intensive group of elderly patients. We've got a lot of the same data in what might be termed the non-intensive group. Where that delineation lies is possibly, Richard might have more to say on it, but possibly in a different place than it has been historically. And also what we want to look at is on an operational basis, the functionality of how we can gather this data. It's quite time consuming and intensive for both patients and treating centres to handle paper, post them back to us, and for us to enter all the data. So we're looking to make this available via a web link, give patients timely reminders. Obviously there's challenges around capturing patients' mobile numbers, etc. But in general, everything that we're looking at, we want to be better informed by patient groups about what sort of patient-reported data we capture, when we capture it, and when we come to look at it, how we analyse it. So we really want the patient groups to be informing us and us working collaboratively with them. Just on one final point about on these different patient populations within the trial, we've recently reported to Cancer Research UK, the funder for AML18, the ethnic and gender spread in AML18, which broadly matches the ethnicity and gender spread across the wider population. So this is my last slide. This is largely a way of signing off and saying thanks for offering the trial to so many different patients in so many different locations. And during the last year approximately of the trial, we might reach out to you and see if there's any patient groups that maybe are not finding it as easy to access clinical trials that we offer. I think I'll leave it there. Priyanka.
Thank you very much. Yeah. Very useful and very important aspect of AML18. And I'm sure there's questions on. I'm really sorry, I'm getting feedback on you talking. Are you Ian? Can you hear me?
I can hear you. All right, Priyanka, I can hear your feedback as well. Maybe I'll mute myself.
Okay, so I'm just going to, before we move on to Richard's talk, I'm just going to take a few questions on AML 18 on Steve and Nigel and Ian's talks. There's a couple in the chat. The first one is about prolonged cytopenias with the second cycle of CPX in AML 18. And is there any data on count recovery, any sort of worrying signals so far? Steve, Nigel, either can take the question.
I'm sorry, I know I don't have those data, so I'm going to have to leave that one to Nigel if that's all right. I'm sorry, Anjum and Paul.
Yeah, I understand some information went to the DMC, but I've not had any feedback. I've not seen any feedback from the DMC. I don't know whether Ian can say anything. The CPX question, the dosage schedule was the same as we use in AML 19, which is closed, and we didn't have issues with, or at least problems associated with count recovery in AML 19 that I was aware of. So that's all I can say at this time, but it is an important question. Of course, count recovery in AML 18, particularly with the flag IDA question, is slower. And I think so we need to compare the CPX post-course 2 with the flag IDA data. So that's all I can tell you at this stage.
Thanks, Nigel. And the second question is from Anjum Khan asking about AML 18 analysis limited to non-transplant patients, and if whether the trial is powered and is going to be able to show us any significant difference in survival for MRD positive and negative patients.
Right, okay. It's not powered to answer that question, but clearly we would look at it. It was powered to ask the question about survival and benefit for survival. So you're looking at a subgroup there. So it's not, but I think it will be interesting to ask that question about the benefit of CPX versus Diego, or Diego 1 versus Diego 2 in the absence of transplant. Yes, we will look at that.
Thanks, Nigel. A quick question from me about the analysis that you said is likely to happen with Paresh Vyas's lab finding, separating out the secondary AML signature patients. So do you think we might be expecting some results later this year on that with regards to informing our transplant decisions?
Well, I think we need to look at all avenues of better defining which older patients should be transplanted in CR1. And I think the genetic analysis and the presence of secondary AML gene mutations is certainly an avenue that we should follow. Actually, there's a collaboration that Paresh has instigated with the HOVON group, which will be over 2,000 patients over the age of 60, all treated intensively. And so we'll have quite a lot of power to look at benefit of transplant in different molecular groups, perhaps and answer this question definitively as about the benefit of transplant in these different populations.
Thanks. And then I'm not seeing any more questions on the chat. Another quick question from me, Nigel. You said the number of transplants were higher in AML 18 as compared to 16. Was there an increase in proportion of over 70s? I know they tend to be a very small number.
That's a good, I don't know that answer, but what I can tell you in AML 16, when we looked at benefit, we found that benefit for transplant, I didn't show the slide, but it was the same benefit depending on in the age group 60 to 65 or 65 and older. We didn't go up, there were very few patients in AML 16 who were transplanted over the age of 70. I think it was half a dozen. In AML 18, there are more, but we haven't looked at that population separately.
Thanks, Nigel. Okay, that's Ian responding to Paul. When the DMC has reviewed our data, we'll certainly feedback on. Okay. Ian, with regards to the quality of life data, it's also going to be quite relevant to match that up with, the duration of inpatient stay and transfusion requirements in the patient. So are we going to be able to marry those factors up in assessing the quality of life?
Yeah, we're certainly looking to do that in the in that Blood Cancer UK funded project, and we're hoping that that will be a little exemplar for us within that little subpopulation that we can broaden out and use across AML 18, and then hopefully that will be useful for future trials, that we can build a way of clicking the quality of life data into the resource use, as you say, is critical when the patient reported data points us towards fatigue so clearly.
Sometimes I worry, Ian, that quality of life data returns are a bit biased in that they are returned by people who are having a decent quality of life. And is there any way of sort of mitigating that bias? Do you think you have a good spread of returns?
Yeah, there's imputational models. I've got to be careful I don't disappear too far into terms that I don't know well myself, but we're working with some statisticians in Europe who've developed imputational models to almost replace missing data. You've got to make certain inferences about the data, but it is possible, yeah.
Excellent, thanks. That's reassuring enough. Right, over to Richard Dillon to do the Victor chat update. Thanks, Richard.
Thanks so much. Can you see my slides?
Yes.
Oh, great, brilliant. Thanks for having me to do a very brief update about the Victor study. So this is a phase 2 study comparing venetoclax with intensive chemotherapy for NPM1 mutated patients. And we hope if it's successful, it will go on to be or at least part of a NCRI phase 3 study. I'm just going to talk you briefly through the pre-existing evidence that led us to set this study up. So there's a number of studies now pointing at quite remarkable efficacy of venetoclax and low-dose chemotherapy combinations in NPM1 mutated patients. And in this slide, I've just plotted the CR/CRI rates for the phase 2 and 3 studies that have been published so far. And in the middle column, this is the CR/CRI rates for NPM1 mutated patients, and you can see they're in the range 80 to 90%, roughly where you'd expect to achieve with intensive chemotherapy. The kind of outlier figure actually being the BRLI-A study, ASFN phase 3 study, potentially due to that. It's not quite clear yet why that is, but we think that may be to do with the inclusion of greater number of FLT3 co-mutated patients. And then looking at survival according to genotype on the bottom panel, the NPM mutated patients are in the blue line, and you can see that these remissions appear to be fairly durable in a proportion of the patients, and indeed in 3 of the 4 studies where it's reported that median overall survival for NPM mutated patients has not been reached. And so therefore the obvious question is whether for that group of patients, whether you could substitute venetoclax for intensive chemotherapy, which might have significant benefits in terms of resource use, quality of life, etc. And then there's also this retrospective data set from MD Anderson that was published last year, looking at their single institution cohort of patients treated with HMA venetoclax, which is in the dark blue line, intensive chemotherapy, which is in the turquoise line, and then single agent hypomethylating agents on the green line. And you can see, well, this is obviously very prone to biases, etc., but you can see in this whole cohort that they appear to show roughly equivalent outcomes in the whole cohort. And in specifically looking at patients age 65 plus, which is in the right hand panel here, they appear to show that the HMA ven treated patients did better than intensive chemo. Of course, this is going to be incredibly confounded because of the fact that venetoclax was only introduced relatively recently, so these will be much more recently treated patients with better supportive care, etc. But it certainly makes the randomized study worth performing. Although, as I'll show you, I've got some real world data which I'll show you in a couple of secs, actually, that we still definitely think that is definitely equipoise about this question. So just a bit about the trial design. So this is a phase 2 study, and we've designed it as actually a non-inferiority study, for the reason being that actually if the outcomes for venetoclax treatment were the same as intensive chemotherapy, then that would be a good outcome, and in view of the patient quality of life and resource use benefits that are potentially there. The trial actually is done in an adaptive design, and what that means is we start with patients aged 60 plus. We believe that they're the ones that stand to gain the most benefit from this, in view of the fact that the rates of induction death rise significantly with intensive chemotherapy above the age of 60. But however, if there's a series of interim analyses, and if non-inferiority is within pre-specified margins in these interim analyses, then the age cutoff can drop, actually can go down to 50 in the first instance. And in terms of the primary endpoint for this study, phase 2 study, we've chosen molecular event-free survival. The reason for this is that then we can then allow patients in the experimental, but actually also in the control arm, who are not doing well in terms of their MRD response, so they have failure to clear MRD to satisfactory levels, or they have molecular relapse. We can actually allow them to cross over to, in the case of venetoclax, they'll swap over to receive standard chemotherapy. In the case of induction chemotherapy, they can actually receive venetoclax in a crossover. However, it's important to point out, because we did have this come up recently, is that we don't allow crossover for toxicity in the current versions. If a patient has excess toxicity with induction chemotherapy, we're not currently allowing them to cross over to venetoclax, because that would not be an event in terms of the endpoint. And our secondary endpoints, amongst others, and Priyanka's leading on this actually in particular, and I think it's going to be quite an important output from this study, is looking at patient-reported outcomes and including comprehensive geriatric assessment. And Priyanka, I don't know if you would like to say a little more about that.
Richard, the only thing I would say is this was the perfect premise for assessing patients from the geriatric point of view, because that's always the question: is the frailty of a patient really influencing outcomes outside of their disease biology, and how we select treatments? And because this study was doing both intensive and less intensive treatment approach, it seemed like a very good place to do this kind of work. So thanks.
Thank you. And so this is how it works in detail. So we are only enrolling patients with the NPM1 mutated FLT3 ITD negative genotype. So we do have some preliminary evidence to suggest FLT3 ITD mutated patients don't respond so well to venetoclax, so they're not included. So and this is the first time really that we've done a national study like this, which only is recruiting this specific genotype. So this is presenting its own challenges, which we're gradually overcoming them bit by bit, and that obviously has to fit in with local centres' diagnostic approaches as well. So that's been quite interesting to work on, and I think we still have to optimise that a little bit. However, as part of the study, we are offering a rapid molecular screening platform in which we can screen for FLT3 NPM mutations within 24 hours of receiving a sample. Also, we can accept for local results. Anyway, on confirmation of this genotype, which we expect to see in about 1/4 of all patients in the relevant age group, patients are randomised. It's a 1-to-1 randomisation done by computer system, so it can be done during out of hours. And they go on to receive the experimental arm, which is done on the left-hand side, which is 1 year's treatment with venetoclax and low-dose cytarabine. And then there's a year of maintenance with venetoclax alone. If the patients respond well in terms of their MRD response, they're on the green line, they just carry on with the treatment and then stop. If they're doing badly, which means when they're on treatment, they're failing to clear the MRD to satisfactory levels, or they have molecular progression or relapse during treatment or follow-up, they then would switch over and they would receive standard intensive chemotherapy, plus or minus transplantation if eligible. On the other hand, if patients are allocated to the in standard of care arm, which is DA plus 2 doses of Mylotarg, if those cases where a patient experiences molecular failure, the standard of care would be for them to receive salvage chemotherapy, then transplant. But however, we recognise that a high proportion of these patients will be unfit for that approach. And for those patients who are unfit for allograft, they can then go on to receive venetoclax-based salvage treatments, which we know are very effective, but are not yet currently approved across the NHS, although some centres do have access. So it's another potential advantage to entering patients into this study. Here's the current eligibility criteria. So as I mentioned, we're starting with age 60 plus. Of course, the patients must be judged to be fit for intensive therapy by the investigators, as one of the arms is intensive chemotherapy, and they have to have this particular genotype. And this could be done either locally on your local molecular labs or centrally on a centralized screening platform. And I just wanted to show a couple of slides about the real-world data sets that has been collected by Jad Offman, that many people on the call will have contributed to. Thank you very much for that. This was a unique opportunity to collect real-world outcome data from venetoclax treatments during the coronavirus pandemic. And we collected information, thank you very much, of over 300 patients, about to do another data collection round now. Essentially, this cut is looking at NPM patients eligible for Victor, so the eligibility criteria I showed you. CRI rate is over 80% in the real-world setting, even during coronavirus, which is quite impressive in my view. And overall survival is approximately 75% at 1 year. And this is comparing those results with a similar genotype in AML 17. Admittedly, this was more than 5 years ago, so with all of the biases that entails, although these patients were substantially younger than the patients in the real world cohort. So all this is just to say, we still believe that there is definitely equipoise between venetoclax and intensive chemo for this group of patients. I don't think there's any real data other than very confounded retrospective data sets to say that to help you make the treatment choice. I think the results of this study will be hopefully very informative for this in the future. And actually the German SAL group are actually conducting a similar study as well. They're using venetoclax azacitidine as their comparator, and they're enrolling patients actually any age of up to 18 plus. So I think together we've coordinated the protocols between these two studies so they can be meta-analysed together potentially in the future. And whereabouts are we with the trial recruitment and setup? We're aiming for a total of 35 UK sites. We have 19 UK sites open, and they're listed here. And a number of people on the call have already enrolled patients in this study. New Zealand, actually, hopefully getting the first New Zealand patient in this week. Denmark will open in about 3 months' time. We've screened 32 patients at randomised 12, and we have a target recruitment of 156. So clearly we've got some way to go, but thanks to all your support, I'm sure we're going to get there. And just wanted to mention very briefly that there's a number of different ways that you can enter this study. So either using the rapid screening platform or the local results. So I've just listed 3 scenarios here that you could the patient could go through. First of all, they could come in with pancytopenia, some blasts on a film. Bone marrow has not yet been done, but the white count's not too high and the patient's very stable. In that case, you could consider sending us blood for rapid screening. We could then report that back within 24 hours, and if the patient does have this eligible genotype, they could enter the trial and then have the diagnostic bone marrow, which could also be the trial bone marrow. So that means the patient only has to have 1 bone marrow procedure done. Second situation, the patient might have confirmed AML and bone marrow is being done locally, and you've taken an extra sample of EDTA, but you don't yet know the molecular status, so this might be quite a common situation. We have a separate consent form for the rapid screening process, and you can actually send the blood and bone marrow. For that, we can do the rapid screening on that. If the patient's eligible, that can be the patient's baseline trial bone marrow. If the patient's not eligible, those samples can actually be forwarded to Cardiff for MR18 if you're AML 18 site. Finally, if you already have confirmed the diagnosis of AML and you have a very quick lab to do the turnaround locally, and you already have NPM1 mutation status, the patient can just be enrolled directly into the trial based on those results and have the baseline trial bone marrow. And I know that a number of sites have come up with kind of bespoke arrangements to make this work in line with their local diagnostics, and really happy to work with you to try and refine that, because I think it's going to be really important for other studies that we're going to want to do in the future with different targeted therapies looking at different molecularly defined groups. So this is possibly the most easy one to start with because it's a very simple molecular test. So if we can get it right for this study, then we can hopefully have the know-how in place to do more complex studies in the future. And we're very keen to hear from you. If you would like to be a trial site, or if you would like to have a patient that might be suitable, we could advise you about where your local site is. Thank you very much for your attention.
Thank you very much, Richard. That was really, really useful. And I have a question in the chat, which is from Manish Jain. He's asking, is there a trend towards delayed count recovery as seen in Venice?
No, we haven't seen that yet, but I think the furthest number of cycles that the patients have had is actually 4 cycles so far. And I don't know what other people think, but I think that we don't seem to see the delayed count recovery until we get to like 5 or 6 cycles with venetoclax, from what I've seen. So it'd be important, of course, to keep an eye on that as a safety signal, but not so far.
Thanks, Richard. I suppose that's going to be monitored very, very closely in trial, because that's been the experience with venetoclax during the COVID times, where we were running into problems with count recovery. So the next question is from Deepak Manare. He's asking, how did you pick the number of courses of when? Would NPM1 MRD results change this?
Yes, it was arbitrary, of course. So we got kind of external expert opinion from Andrew Way and people that had treated a lot of patients with this regimen, and about how many cycles they would give until they'd be happy to stop. Certainly, I think the patient needs to be negative by the time that you stop treatment. We have seen a variety of kinetics of MRD clearance with venetoclax treatment. We've seen patients just go negative after the first course. We've seen other ones take a lot longer to clear the MRD. It's really not clear. We're trying to do some translational projects to try and pick that apart and understand whether that we could identify that based on the genotyping, and that actually might influence which patients need more or less treatment. And it might also, you could even think it might influence the intensity of the treatment in terms of the dose and the length of each cycle. But at the moment, it's all quite unknown. So it was arbitrary, and of course we may have to amend that. How we have defined molecular failure in the ven arm is if they get to a 4 log reduction after cycle 4. And that was based on an analysis that we did in AML 17, where that seemed to be a cutoff, end of treatment cutoff, that was predictive of relapse under intensive chemotherapy. And of course, we have to have the same endpoint in both arms. So that was the reason for that. So somewhat arbitrary on both counts, might need to be amended. This is a phase 2 study. We're early days experience really with this treatment. I know vast numbers of elderly patients have been treated, but the number of patients treated with curative intent has been, internationally, has been really small, and there's not that many studies going on in this population.
Thanks, Richard. Whilst we're waiting for any more questions, the crossover design, it's very, very attractive. But because you're allowing bidirectional crossover, is that going to make your analysis difficult?
It will confound some of the secondary endpoints, of course, overall survival in particular, but it won't confound the primary endpoint, because anything that makes you cross over is also counted as an event for molecular failure. So it was we thought it we had to allow really a crossover from venetoclax to intensive chemotherapy, because it's a substantial de-escalation in terms of the treatment intensity. So yeah, so that was the main reason. But then also we know that ven-based salvage works very well for patients who've had previous chemotherapy and it's not universally available. So that was kind of an extra bonus for the patients.
Absolutely, like I said, it's an attractive part of any trial, any study when they're offering crossover, and it does make it easier to consent the patient when you're telling them that, you know, yes, there are two very different approaches, but if one doesn't work, we can always switch to the other. So I think that should really help in trying to get the message across to patients that, you know, this is, we're not really deviating very much from standard of care there. So Ian's asking a question about reported data you're collecting. What patient-reported data you're collecting in Victor, Richard? Is there scope to compare with the AML 18 PRO data set?
Question for Dr. Meter, actually. No.
I think patient-reported outcomes being collected in Victor as well, and whether we'll be able to compare it with AML 18 Pro data set. I think some overall messages are going to be similar, and overall sort of the more basic indicators and factors will be similar. I haven't actually ever put the two side by side to see if they're how much commonality there is, but yeah, I think no reason why not.
Thank you.
Are there any other questions for Richard or Steve or Nigel from anyone? So, Richard, have you got a sort of, I'm sure you've shown this, but the timeline for Victor recruitment?
We're hoping to recruit over 2 years. Is that what you're asking? How long we're going to?
Yes, yeah.
We're hoping to recruit over 2 years. It may be that we got a bit behind because we started during the end of the pandemic. A lot of sites are delayed in setup. But yeah, we're about 6 months in now. So.
And have you got as many centers as you were hoping to open?
We have in setup, yes, but a lot of some of the sites have had to drop out due to redeployment, coronavirus, backlog, etc. So we're really keen to hear from other centres that would like to become sites that maybe didn't consider it the first time, but now find they have capacity or would be enthusiastic. We definitely have scope to take on possibly up to 5 new centres in the UK.
And Richard, if say a certain center is not signed up to Victor, but if they had a patient, and because you've shown that flow diagram where the samples could be, you know, any where they're suspecting an AML and all it needs is 4 tubes to be sent, do you think they could sort of, and if they had a center nearby that was a Victor center, that they may be able to just refer and do it as a screening via that center? Is there some way that?
No. That's annoying because that's not allowed under the current law, unfortunately. We looked into that quite extensively. So what they could do is they could send standard of care samples to the local labs and ask them to rush it through, but they couldn't send it to us because it's a trial lab. If the patient hasn't at least signed the 1-page screening consent form. So this is all of these are like minute, they sound like minute issues, but they actually make a lot of practical roadblocks that we need to try and overcome. But I think it's important that we try and engage with them because it's going to be important for other things in the future.
It's just because, like you showed, there's a distinct, I mean, those populations in AML 17 and the numbers you've collected in the COVID pandemic, that the numbers are there out there. It's just about how many can access the trial. So excellent. So there's another comment from Nicola Beans. As someone who's alarmingly close to their 60th birthday, I'm encouraged by the ongoing work presented at this meeting. I continue to be a glass half full kind of person. Well, that's excellent to hear, Nicola. We all keep working purely with the enthusiasm that we have, is because we think we can continue to make a difference and improve things. And I do think AML 18 findings, as Nigel has shown, has really been remarkably shown some progress over AML 16, and it's just such a sort of testament to all the work that is planned and delivered in these very large mammoth trial. So again, a huge big thank you to all the participants who are recruiting patients into this study, and to patients as well for complying with the treatment and responding to the QL questionnaire demands, etc. So big thank you to everyone, and a big thank you to all the speakers. It's always nice to go through the basics of all the trials that we're treating patients in. And there's no more questions, and we are going to finish 4 minutes ahead of time. So thank you all, and have a nice evening.
Thanks, Priyanka.
Bye.
Bye, everyone.
Bye. Bye, everyone.
Bye.
Ian, you've got the recording, yeah?
Yeah, I thought I'd wait until everybody had left before I turned it off. So thanks for that, Priyanka.